start your camera, you also will be seeing it. Start your laptop. Come again. Scuba, what was it?
Good evening, sir. Good evening, ma'am.
System.
I am Darshana Kope. Hello. I am Darshana Kope. Today's topic. Reading has 7 months to God. Also, but one of the not
Hello, sir, sorry to disturb, but we cannot hear your voice, ma'am's voice.
शुरू कर
11 and 7 months of boy. Third by birth order. One of the non-consensual marriage. Representing the harmful. Failing from Uttar Pradesh. Muslim by religion. Shaped by community. Brought by an empowerment in art. Exact. I was not able to find someone. Start. After 25 days, the little doctor which was sudden and after an intervention, and it must be good. Second episode for fun was that of similar plastics are around 5 minutes, followed by 14,000 and 4. So I was shown to a doctor where he was advised to use it because that's how it's focusing on. There is some output. Earlier, child was in seconds to focus on the work. Currently, it's finding the reward setting and trying to fix it. There is some full absenteeism and reduced collapse performance. This is just total neurological aspect. No history of impaired consciousness is orientation. Mouth, drooling of saliva, vision, regurgitation of food. No history of miscarriage. No history of previous episodes of conversion or developmental delays. No history of sweating, flushing, pallor, or coma. No bowel bladder incontinence.
Sir, sorry to disturb again, but no audio is there.
Yes, no. Audio, sir. One day. Yeah. Nice. अंजलि को पूछता हूँ. Okay, so now start analyzing these complaints as they came in. What would you think? What is the meaning of the first complaint? 3 months back, and notice that he's forgetting things no good. What would it mean? Whatever comes to your mind. Suppose they said that he is not able to remember tables in school, like 2 2s are 4, 3 are 6. Then what would you ask? What would you check?
This comprehension. That is comprehension, whether he is able to understand. Next are other things like his handwriting, simple mathematical calculation, whether he is able to do that.
That is later. So basically, you already got into that mode of trying to look for associated sins. First, if somebody comes to you with a complaint that he is not remembering things, you need to first confirm what he is not remembering. Secondly, not remembering studies could have many reasons. He is not very interested in studies, he is not focused. You have to look at other day-to-day things like does he remember advertisements, does he remember film songs or etc. And then come to a conclusion whether it's really a problem or it's a selective area that is right. Or apparently she's saying things don't feel like the address and things that you've been told to buy yes for corporate. So that probably is significant. Then which part of the brain does it suggest? Anatomy means I'm trying to ask you for anatomy.
Temporal.
Here, cortex, subcortex, white matter, gray matter. Obviously, no gray matter. Okay, so these are cognitive or memory issues. So gray matter. Then next, he was not able to follow commands and do tasks as he used to do previously. So here again, what does it mean?
Maybe some understand it properly.
One is understanding, so that is comprehension.
Comprehension.
But what else? Again, if you look at it wider, it could be a sensory problem. Suppose his hearing is getting affected, he is not able to hear what you are commanding, then he's not going to follow the.
Yeah.
Okay. Then there is auditory inattention, which is separate from auditory impairment. That he is hearing, but he is not. Okay. And third is cognition. That is comprehension is getting affected. Right?
I think the problem is also memory. When we are talking about memory, there are three types of memory. One is for recent event, one for known event, and one is skill memory. Skill memory doesn't come in the way of a medical properly, but just to make a complete understanding of memory, recent and known. Now, these are all coming from different centers. The recent comes from the frontal cortex. The old memory comes from subcortical level. And skill memory, what is skill memory? Once you learn to ride a bicycle, you may not have ridden bicycle for years and you still can ride it. That means some of the skills that you have practiced years, decades ago, still stay with you. Another is swimming, for example. You never forget. That's how those who play instruments and accompany a singer, they don't have to look at anything. It is a skill memory, and he keeps on playing with his fingers, and he knows everything where it is. So the question is, skill memory comes from central memory. The recent memory comes from frontal cortex, and the old memory comes from subcortex. What you must remember talking about this first, whether it is a pathological problem or just environmental problem. But having looked at pathological problems, in adults typically they are distressed. In pediatrics we don't. But this is 11-year-old daughter. They will ask recent memory and old memory. They will ask what did you do yesterday? What did you eat yesterday? And old memory. Sometimes I remember old things better than the recent. But it all depends on which area is not working well. That's why recent and old. So we would have asked all that. What's more important? If the recent and old are all lost, that means the disease is widespread. Just at one area. That's important. And if the disease is widespread, then you want to very carefully anticipate whether it will spread to many other areas. And then there was 1 month, at 1 month the seizure. Where is the seizure coming? I told you about the memory, cerebellum. You will not go about cerebellum, you are not worried much about pathological problems. But where does the seizure come from? Cortex. Can it come from any cortex? Or only the motor cortex? Only motor cortex? Yes. So what's the difference between convulsion and a seizure? I asked you anatomy of seizure. I did not ask you convulsion. What's the difference between seizure and a convulsion?
Convulsion is a motor manifestation.
So it's only convulsion that comes from the motor area. But the seizure may not be motor area involvement. Can we say area? Parietal, occipital, temporal, which area?
So you all know that there are auras. So those auras are the sensory auras which represent each sensory area. So the seizure starts from there and then it can generalize to involve many other. Then you know what we used to call as complex temporal lobe epilepsy. So that was a temporal cortex where you will have partial looking motor symptoms, but lot of behavior problems, right? So different areas of the cortex can get involved. So you have to again decide what is the clinical manifestation. So that came later. But before that now, relative notice jerky movement of right lower limb, which was sudden and involuntary. So what does this mean? What kind of an involuntary movement do you think this is?
I think we need more information regarding this type of involuntary movement. One she has given is that it is not present in sleep. So that means this could be stimulus dependent. So I'll have to ask if there is any abnormal posture or not with that. Or if it's a continuous movement.
So how do you clinically, so which involuntary movements are present in sleep? Sleep myoclonics. Otherwise, none of them are present, right? So that is just a simple, I mean, not present in sleep doesn't help you much in it. So now, what are the other things that you notice about an involuntary movement? Before adjectives you have to give to that involuntary. So what are they? Is this fast or slow? What do you think this is? Fast. So which are the fast involuntary? Tremors, then okay, myoclonic jerks, but they are seizures actually. They're not, but okay, clinically they look like involuntary. Then chorea. Athetosis is a slow movement. Okay, it's slow twisting of the hands. Right. So first you decide fast or slow. Next, rhythmic or non-rhythmic. So what are rhythmic fast movements? Tremors. So you have further divided into rhythmic or non-rhythmic. What are non-rhythmic fast movements? So dystonia and chorea, right? Now twisting or not twisting. So there is no twisting, then it is not distorted, right? So what are the words that tell you sudden is the word which tells you that this is fast, and jerky. So it's like a jerk. So that's why it's fast. So this initially suggests chorea,
Yes.
but it's happening only in one limb. So that's a little unusual, but then there is some progression after that.
How do you know it's important? In the history,
Can you ask something to decide whether it's involuntary? What is the meaning of the word involuntary? Involuntary means, so what do you ask him?
as you come there, for this, is it voluntary or involuntary? I'm sorry, I only know actual life situation. How they know that? If I can correct you easily, then it's not involved. So can I stop you from coming late? If I can, then it's fine. But if I can't, of course, I may not be able to, even it's involved. But the main difference is, and the mother tried to stop it, it is involved. But one more difference, proximal and distal. These are proximal and these are distal movements. So speed, fast and slow, we talk rhythm, rhythmic or non-rhythmic, and proximal or distal. These are proximal and these are distal movements.
Distal is tremor. Distal is the tremor.
And proximal, and as history could suggest, but is it important? There's anatomy in it. If anatomy is same, why bother? After all, you will say basal ganglia. If it is a basic basal ganglia, then why go to the FHT? So is it important on the history to pick up tremors, chorea, the question is, would abnormal movements come from other areas? In the basal ganglia, there are multiple cells. So it's not easy for a clinician on history or even examiner to pick up which nuclei in the basal ganglia, and that's not important. Like, moment this will be some corpus issue, there's no need. But there must be some. There is
Yeah.
an instability. So when you come to cerebral, because cerebral is involved in this chat. But I just wanted you to look at that. So I think that's the way you start thinking about that. Now go back a little. Memory. Did it happen suddenly? Or it came to light suddenly? I perceived it suddenly. I was not studying in my school. My parents did not know. One day they came to know. It was not sudden, not studying. I was not studying for a long time. So what questions would you? This is just to stimulate your brain actor. He said the problem is with brain actor. Anytime problem with us is also brain. Give us.
What questions will you ask? To decide whether it happened suddenly or focused.
It's important. Answer is important. So I want you to ask them that there are subtle some symptomatology which they may have overlooked. That is important. Okay. What shut okay. For example, did he suddenly drop something from the heaven? There's no abnormal moment. But when drinking cup of tea, he dropped it. Okay. That means there was something wrong. Okay. He's going to school, so was the handwriting getting bad? So handwriting could be getting bad for some days or weeks before somebody notices that you have some. Remember to ask all these questions because acute onset is different than subacute approach.
So usually cognitive functions, if they come suddenly, many things will go wrong at one time.
And therefore, many of these things, what looks suddenly is vascular. Okay. This is obviously not vascular because the multiple areas are involved. So what is not vascular is not likely to be very sudden. So when it's not sudden, it could be within 2-3 days. It could be 2-3 weeks. So we need to get into all those details because pathology could be sudden vascular. In 3 weeks is different pathology, and in 3 days is also different. So you must try to find out what could be the onset and then preparation.
So far, tell us what all adjectives you can apply to this story so far. To start with onset. Sudden onset. So subacute or chronic onset. Then progressive or not progressive. Rapidly or slowly. 3 months. 3 months. Nice. So slowly progressive. So subacute or chronic onset, slowly progressive. Where is the anatomy? Which are the areas? So you initially said gray matter, then now basal ganglia, and maybe cerebral. So multiple areas of the brain. So what is the word for that? Multifocal or generalized. And what is the anatomy? It is spinal cord or it is brain. So encephalopathy. So subacute or chronic, slowly progressive, multifocal or generalized encephalopathy. Between multifocal and generalized, the word generalized would be better. Generalized encephalopathy, infective or non-infective? Non-infective, right? So all these adjectives you could put so far. Now let's see what happens.
Acute also could be explosively sudden or just few hours sudden or sudden. Subacute means what? We won't go by the book definition. There could be some definition, 2 weeks, 3 weeks, 1 week. We are not bothered because no patient has read all that book. Even we haven't. So patient will not know all those.
3 episodes a week, asking for half an hour each. So that's very theoretical. I'm wheezing, and you are asking me how long you have been wheezing and how often you wheeze. I read you and say, don't ask me such questions. You are me. So tell me what is the
Inside, inside, yes.
No. So talk in terms of time. So something that happens in 1 minute is what, acute or even something different? Hyperacute or explosive onset. Okay. Something that happens in half an hour, 1 hour is acute. So now what is subacute? Hours to 1 or 2 days.
right? That is subacute. Breathlessness in pneumonia is subacute. Breathlessness in asthma is acute. And breathlessness in foreign body, hyperacute. So the pathology is subacute. Which kinds of pathology are there? infection is out. So inflammation possibly not. Then which type of
Demyelination.
inflammation also, yeah, to some extent, you are demyelination. Is demyelination a gray matter or a white matter? So we are talking about gray matter to get out of demyelination. Okay, that's good part. Okay, now which other and the only other common thing is usually through days, they want to be a this was the it is the degenerated the so that they can reach the ground. You got a diagnosis. So in your general any psychologist, hospital, hospital, but you can find only this, you got the diagnosis, and there could be something more coming up. Let's say we are not asking you diagnosis. So you when the infection of this thing, first it's of very different factor on our part. But if it's autoimmune, then because you can form diseases that I think 102 days it is taken from the so this must be a very slow onset and chicken pox come at night.
And chickenpox come at night.
Chicken pox may come even if the mother has also chicken pox of the child. But it is extremely mother suffers badly, but the infant newborn I use for here and there. They get the chicken pox suffering is used what is most common infection that we get from
How to differentiate? Suppose a relative will tell you Mata, you don't know chickenpox. How you what from the last relative polymorph. Students also can't decide polymorph. Patient is generalized.
yes, right part, but nobody observes where it starts. Okay, who can I start from there? From there? Just suffering and no time. Things we are very similar. So what are the most
So what are the
common
gross differences in
Gross
the appearance of
before skin allergy?
one is macular and the other is vesicular. Simple language you ask them, कोड़ी जैसा था कि ऐसा patches something like
And these are very sick. Chicken pox is not. But reasons has extremely dominant chicken pox. But there's so many questions in the history can make chicken pox.
What was this is? Always remember epidemiology. There is no epidemic of measles around. What is the epidemic around, right? Then what is the age group? Measles not. An easy vaccination. India has no measles. If he is an Indian, less likely. If he is of infant of small 1 or 2 years, are non-vaccinated because of COVID. So we need- And if it is big, then no likely to be. And it could help easy to There's so many things that come from epidemiology which is not known to reality. You just write in your brain and think about epidemiology for every case. There are lots of answers which the examiner doesn't know.
now what is this for? Forward bending movements of neck and then later lateral and backward bending. What do you think this could be? Loss of control, yeah. So it's intermittent, right? Intermittent loss of control. So is it loss of control in the sense of cerebellar involvement, or is it involuntary movement only, or it could be a seizure? What are salam fits? What of salam fits? What are they? So flexor spasm of the trunk. Right? The suddenly the trunk goes forward like this. That is called a salam fit. Classically seen in excessive traveling excess.
Bending, bending is different than loss of force. But the loss of force is suddenly dropping. The story would have been suddenly amplified, suddenly bending. Bending is things that this is not everybody is stability, but considerably reduced. And therefore, lateral, forward, and backward. It's a part of the same movement.
Then difficulty in walking and frequent falls is understandable. The problem is easy. And then those two seizures. So basically, everything is suggesting a widespread involvement of the cortex.
When did the first season?
In the initial 1 month of this 3 month
It
phase.
is not start with loss of memory, then going to develop seizure. Possibly a general seizure. In every time in a seizure, ask whether it was a vocal seizure, and don't forget to ask the history of seizure. Prior to seizure, during seizure. It gives you a lot of first thing it will tell you whether it's a focal, which in general. And then if it's a focal, where did it start from? So get all those. Seizure alone may not be sufficient. Therefore, confirm that it is a genuine generalized seizure. And I think that is what it is. But he did not remain drowsy for a long time. I think with such a widespread progressive illness, he's still conscious. He cannot eat. And I think he wants to live. I'm not surprised that he's still drowned. He's still awake. He's still conscious. I'm not surprised. You are, right? Very well. So my question is, which area in the brain keeps us conscious? Okay, we may not be conscious of what we are doing, but conscious. Which area? Anything else? But we are not talking about the material problem at all. We are talking about context. Is context not important for remaining awake? So why is this your not house? Political involvement, spread out, diffuse, conscious.
Anything to do with the proof of
This kind of politics involved, then you a tricky question, but I'm sure you know the answer. And the answer is bilateral quality. Bilateral. So this is unilateral quality or not bilateral. Right? And how do you differentiate bilateral cortical drowsiness from the midbrain drowsiness?
brainstem reflexes.
You're very clever.
Corneal.
Somebody. In an exam, you are getting diverted like this. Remember that. The diagnosis is not important. And you will come out and say, patient का बारे में तो कुछ पूछा ही नहीं, तो डॉक्टर पूछता, okay, knowledge now. You're right, my friend, but doll sign, and how does a doll sign differentiate bilateral multiple from the
What exactly is God? What do you do? What should happen? What does it tell you?
We turn the head to one side and there will be, we turn the head to one side and there will be contralateral deviation of the eyeball. So it indicates intact brainstem.
So tell me, in which of these two, doll sign is positive and negative? You don't have to remember this. It should be still and memory.
In a company, if the CEO is not working, who takes charge? The next in command. In the brain, if CEO is not working, then who will take charge?
Brainstem.
Brainstem. So if your doll size is positive, it means brainstem is working properly. It means CEO is not working. The cortex is gone. And what will happen if cortex is intact? This movement will not happen. The contralateral eyes will not happen, right? Because cortex is intact. You turn the head, eyes will also turn, right? That's the.
This is important for exams and you come change into. Next question related to that is, could a unilateral particle be vision may be unilateral. But vision could be unilateral, but the effect is bilateral. And space occupied vision. Typically a subdural waveform which goes on in large zone, it's not picked up. With such compression and the whole node based on to compressing the other node. And both nodes are involved. So if a subdural fellow is unconscious, you already missed it for a moment. If a subdural fellow, we should not get something.
Then speech output has gone down, which means Broca's area is getting affected, and then there is slurring of speech. So now this slurring of speech makes it more strong that possibly cerebellum is also getting involved, right? Earlier we were debating whether they were.
Is language Broca's area temporal or frontal or both?
Focus is in front.
Frontal and temporal.
One is your face.
So can both areas be involved with language? Okay. These are important. Neurology is completely like that. 1 plus 1 is 2. Based on medicine is very well. It would be very bad. But anatomy correlation is very strong in neurology. So where does the receptive language come from? And the expressive language.
This is one.
So typically we see in adult, we don't see so much in children, but you see sensory aphasia and motor aphasia. And what is their word output? Decrease. And sensory fluent. They talk nonsense. It doesn't have meaning, but they keep on talking, right? So they have opposite clinical manifestations, right? I think the rest is all fine. So now what we have already decided that this may be autoimmune, this may be generalized encephalopathy, all that we have decided. Come tell us your.
You all say regress. But when we say regression is regression, regression development is nothing else. And any sick cell, if you have an ICU cell with active pneumonia, then we don't say not going in there
will decrease its work and partially eliminate the moment
Differential diagnosis is different than differential diagnosis. Differential diagnosis is what all can it be? And she has said all can it. But we already ruled out many of them. You could start saying that, oh, you should like it with that. Something of that kind. So if examiner knows that you have taken the note of different pathologies, so also not degenerative, so also not infected. Okay. So very likely autoimmune, not just an isolated movement disorder. And you know, rheumatic flora is a movement disorder. Does it have any change in the area? The answer is yes. Telling you that rheumatic flora is not isolated because they but also incident. The incident was very limited.
Emotional ability.
To take a note of all that. And therefore, we will be talking about movement disorder. Two these two seizures coming at different times would be epilepsy. So what's the definition of epilepsy?
Higher risk of developing.
The most important part of epilepsy is not trigger. Okay. They obviously trigger. So these are acute symptomatic seizure. And therefore, get rid of epilepsy, also not movement disorder alone. So finally, it will be autoimmune. And you could have put up to say mostly autoimmune instead probably. But to keep in mind other messages in case the registry here is not very perfect, etc. And what autoimmune that disease that 9 months must be responsible. It takes few years to develop an immune response. That things appeared for MD this decade, and they said I felt it in another 10 years later. How can it be? It didn't come up within a short time. AGN, rheumatic fever, they take longer time to see which GDS, I think it may come in 2, 3, 4 days. So do you think autoimmune means happen very time? What have you learned in this pandemic? The immune responses in adults come even after 6 months, 1 year of a myocardial involvement, cortical involvement. But I can understand months. This is 10 years. Can you imagine? I fell down and developed fracture 10 years later. Past history of thought. That's your comment. I'm sure you know SSP comes later, but how is that?
What is the full form of SSP sclerosis? What can happen over time and sclerosis? So it's a sclerosing panencephalitis. So that sclerosing has been happening for a few years gradually. Clinical manifestation has come.
And the most important part of SSP is that the virus is still alive in the central nervous system. Okay. And if you do the antibodies and CSF, they are still. The virus is lurking. And even during COVID, we feel that COVID is fine, but somewhere the virus is lurking and the immune reactions may come 6 months or a year later. And today, therefore, in adults in particular, if people ask for post-pandemic, what did you suffer from? So that's why autoimmune will come much later because the virus lingers in the some tissues. Okay, does TB linger on even after cure? Bacteria? Where do we live? That means I am never cured of TB.
reactivation of latent tuberculosis.
Reactivation means they must be there somewhere. No? Where are they alive? A powerful form, no? One acting intracellular, other intracellular, every kind, having compliant. Even then I will have one vaccinate some. Sorry, you can never cure or get rid of the last antilocal activity. You always remain, and they are alive, but they are under immune system check. And it's like a criminal is all around in Mumbai all the time, but he's not active. He's waiting for a chance to remain active. And what's that chance for mycobacterium to start activity? So, measles, then your immunity goes to measles and you go waiting for a chance, but live. So this is what it is. Now somebody come here and as usual, first talk about what you see in this.
Start speaking
Come,
fast.
come.
So the child, there is
First, first is growth and sickness.
the child seems to be well, moderately nourished. He's not acutely sick. Involuntary movements, like, inappropriate laughter. He seems to be having, he seems to be encephalopathic, altered sensorium.
Why you say altered sensorium?
In the sense like this involuntary movements, this
Involuntary movement is not altered. What is altered? What is consciousness? And what does consciousness mean? Ability to respond to environmental stimuli is consciousness. So it is not that he is not being able to respond. He is looking at you. He is aware that he is in front of you. Right? Mubarak,
आपका नाम बताओ कहाँ रहते हो कहाँ रहते हो हाँ बताया कहाँ रहते हो you look at small letters, let's say, and I ask you, where do you stay? You know, because people all that, he's looking around actually. Not bothering about that, but he's smiling out.
so he is conscious. Okay? Consciousness is conscious. Then what else?
and jerky movement by a clonus
Involving the
whole body.
But this is Korea. No? Typical Korea.
So you will be continuous with the same move. Okay.
At this point, he's crashing his legs and that too sudden jerk. Okay, it's not sudden.
anything else? Any cranial nerves you see?
Any cranial nerve? Can see 7 is all right, 4, 6 is all right. He's able to answer this stable, it must be all right. I'll go with them as a one. So, these cranial nerves are all right. What about motor system? What motor? She's moving, there's power involved. Tone is all right. Currently, no
In such a question on inspection, what will you say? No hypotonic or hypertonic postures.
mild one you will not pick up. Okay, so power tone, abnormal moments you already talked about. Incoordinate. There is no need to test all this in but there is no mistake. It's stable setting. It is not tension. So we know that much. Nutrition is done. The motor system is done. And you know that it's running all right. Absolutely normal. There's nothing else prior to it. So we got everything what we have got in there. See,
This was a myoclone.
we studied those. This is the same abnormal movement. And abnormal movements in neurological disorders are also mixed genes. If we know choreo and psychosis, any of them can be together. So all that you have is, yes, it's like
Chalan.
so he can understand also. आस्ते आस्ते हाँ आस्ते चलो आस्ते इधर है इधर आ आस्ते आस्ते चलो हाँ वापस आ जाओ वापस आ जाओ वापस आ जाओ शाबाश Yes, they have a- So what do you look at the page? Right. What do you look at the page? So what issues do you look in the page? Then you say broad.
The swing component
Swing
and stance.
stance.
Very good. So what is that? What is stance?
What is stance?
Stance is the lifting of the leg, and then till the time it again it's kept on the ground.
You strike the ground and your leg goes like this, then your leg goes like this. That is the stance. This whole thing is the stance. Strike, stance. Okay. And what is the swing? Movement of the rest of the body. Right? So in him, what did you notice? You said wide based gait. So he's right. He was keeping his legs wide. Why?
Cerebellum.
Cerebellar, as in he was losing his balance, so that was his compensatory mechanism. Then, what else did you notice? Okay, so he had difficulty in stopping and turning. So, which is a sign of, you see in Parkinson, no? So again, basal ganglia issue. Then,
In fact, the minimal involvement is while turning he becomes clumsy. And therefore the first time would be
there was a mild lordosis, which was also part of that balance issue. And that strike was not very typical heel strike. It was because he had no proper control over his muscles or judgment of the distance. So that strike was not like this. It was not what you and I walk like this. So these are the things that happened that we saw in his game. Right?
So thank you. Hello. Okay.
Just quickly tell us the final diagnosis. XST is
and slow way.
So working diagnosis is assessed.
No, that's supposed to be any abnormality. Very normal. MRI. Like different kinds of it's an MRI is normal. Oh God. An MRI is normal.
This is just structural. You can see the functional disturbance.
So the imaging is used as a function. Imaging is structural. And this is a functional disorder. And therefore we have to face the function more than structure. You're lucky if you see something in the structure. Okay, but structure is not damage, like an infant is a damage. Okay. But this is a functional disorder, and therefore we are not surprised that MRI is normal. In fact, one might not have that. When we were trained, there was no MRI, and still we could commit an SST. Because it was very good stuff.
And good presentation.
Well done, well done.
So we'll do one different exercise. We'll do only examination. We know, see, this is CVS. Come.
After being examined and given, let's look at whether we can understand also what history is that. Can we go on?
That other one. So just see if you want to tell them or what. ये गड्ढा रखना है क्या?
बैठ जाए इधर, इधर बैठ जाए। शाबाश। इशारा है तू।
Sir, sorry to disturb, but can we increase the voice audio? Sir,
Sorry?
Pallavi here. Pallavi here. It's not clearly audible.
इधर आप बैठ
Yeah, we don't know what is the problem today about the audio, but we
Okay.
are doing our best.
Okay, sir.
Was this
Okay.
audible?
You are audible, but voice quality is very low. So we are not getting some words, or sometimes it is getting too low.
I don't know what is the problem. We are not able to figure out.
आम्ही त्या पुढच्या वेळेसाठी करून दाखवा
नक्की सर, नक्की. काही नाही. Okay.
check that first. Very good. This normal way where she wants to stay confident. Okay, come and sit here with so many doctors there.
Do you think it's a normal behavior? Even those who present also don't come so confident. Okay. So do you think it's normal? That means she's used to failure. Okay, all that, yeah. Yeah, wait, yeah, no, no, like it. Ask me about it. Only examination, no history. Come on, somebody is senior close. Come on.
मम्मी आए उधर?
Come on, go ahead. Yeah, he has been very active. We will give him a little rest. Of course, he will add on. Okay, come. First inspection. Take a mic and. As you examine, you give a running commentary also. Okay, so we know what you are doing.
And the tissue paper करो. Okay. Inspection. Ensure normal. Not equally with respiration.
But the right chest is all depressed. There must be fibrosis, collapse on the right lung. Yeah, I can see it. Right is depressed. So right is depressed is.
Maybe the left here. Maybe the left.
So you think the left is more prominent? The whole left. What? A big tumor there in the left side? What is there?
Increased precordial.
So the point is, when in an examination you put down, make sure that the spine is all right, the bed is all right, and the correct way is you be at the level of the chest and see. Okay. When I see from here, I see the right side is the chest. So always look at that, right? And the best way is to look at from the foot end, and then you see abdomen, chest is observed by being at the foot end and at the same level. So you have never done it in 3 years, but in an exam do it. Okay. Because some examiners are very particular, and that's right. That's the right way of doing it. Okay. So go ahead. Any concessions?
After purchasing other is more of you are on the left 2 feet of space.
Below the left. Apical impulse visible below the left nipple, sir. Lateral to the mid-clavicular line. And one more visible pulsation seen in the second intercostal space, medial to mid-clavicular line. And also we can see the carotid pulsation.
Good. Okay. Is there a hepatomegaly? On
There is no
inspection.
visible bulge.
On inspection. No. Yeah, abdomen is quite flat, so there is no hepatomegaly. Okay. So possibly. Is she breathless?
Child is breathing at a normal rate.
So no breathlessness, so no cardiac failure, neither left-sided nor right-sided, no edema. So we are looking at many things on inspection alone. Any precordial swelling? We said no swelling anywhere, but we want to know precordial because you talked about pulsations.
It is pansternal bulge.
So no significant precordial bulge. Okay. What does precordial bulge suggest?
Hypertrophy of the.
So something is pushing outside. So that is not there. Okay. Palpation.
That may not be very severe. Some degree of hypertrophy is still possible.
One more doubt we have. So in inspection, like when we describe the apical impulse, so should we tell the intercostal space or in relation to the left nipple?
No, she said rightly nipple line. Okay, she has not counted the intercostal spaces, but nipple line, which is fine. And that's a reasonable thing. Nipples could be at different places. But nipple line is a good statement made on inspection, right? Palpation.
My
And palpation, apical impulse, apical beat, apex beat is palpable at the level of the lip bone, the fifth intercostal space at the metaphysical line.
So do you palpate like this or like
Then we will
do you palpate like this? I want to palpate the intercostal spaces. Everything is in the intercostal space. You said fifth phase. You could do this way. That's much better to pick up, isn't it?
So first you do this to see where it is, and then once you have localized it, you do this.
And in exam, such small things do not matter. But if somebody asks you a question, he said, at my center, we have not been trained like this. So they may fail your teacher, but not you. Okay, so don't say, no, no, how can it be? Sir, in our center, this was not emphasized. Okay, but that's a good way to go by. First arm and then, okay. What kind of apex is that? Normal, hyperdynamic, heaving, tapping. You know it is not heaving, right? And you know it is not normal. Fine. So confidence they say it must be hyperdynamic. Okay, but it may be normal as well, even in a high person. Okay, all right. So that's the palpation. With inspection, you look at the neck veins. Don't forget that also. And you look at the neck veins at 45 degrees. Why 45 degrees? You can see it lying down, no? I mean, can you not see lying down? Or maybe sit up. Why 45? Makes me very uneasy at 45. Okay.
45 degrees of the intrajugular vein and right atrial line. We can measure the JVP.
It's not that they are in line. So you want to see the upper end of the internal jugular pulsation. So in this position, that upper end is beyond the mastoid, so you can't see. And in the sitting position, it is below the clavicle, so you can't see. So 45 degrees so that you see it in this zone somewhere.
And what you meant was the pressure in the right auricle corresponds with the upper level, and for that you know. External jugular or internal jugular? No,
So can you see the internal jugular?
I can see external jugular, not internal.
So pulsations of the internal jugular. So
Why not external?
So internal jugular is the one which forms the superior vena cava, and superior vena cava eventually drains into the right atrium. So internal
jugular vein has valves inside. So the pressure does not come relatively well. Internal jugular has no valve. And therefore it reflects the correct right atrial pressure. That's why the internal jugular, right? So that's one. Also, as a routine, therefore, neck veins are important part of the clinical examination and also the abdomen. Okay, percussion. So do you percuss a heart disease or not? No. Why? Technology has increased. Why percuss? What's the reason why no percussion? So at no age you percuss nowadays. The heart disease. Of course, lung disease you must percuss. No doubt. You often there was stony dullness. Last time also there was some stony dullness, and I asked which stone was that. Okay, and have you ever percussed the stone? So even in cardiac disease you don't need to percuss.
Okay, so pericardial effusion.
So you need to, no? Then why did you say I don't need?
On inspection and the palpation of the apex beat, if we are not expecting pericardial effusion.
inspection, palpation, you are sure palpation is not required.
Outer border.
In an infant and a small child, percussion is difficult to make out. That's why you don't. But in a bigger child, you must make it out. Okay. So as a routine, yes. So now show me how.
But before that, in palpation, what else? Parasternal heave, it's there or not there? Here. Show how you will look for it.
Left side or right side?
Yeah, left parasternal heave. So it is, left side of the midline. It is there. Okay. So what does it indicate?
Yeah, that's right. That is better.
So then which other signs of right ventricular hypertrophy will you look for? Look. Look mean not visually. You have to palpate. Deeper. And push up. You can feel. So you have to decide whether it's right ventricular pulsation or aortic pulsation, because this is a thin girl. So if the pulsation is hitting the pulp of your thumb, then it's aortic. That's normal. If it's hitting the tip of your thumb, then it is right ventricular.
No true. So when I auscultate, it's much easier to know. So why palpate the thrill?
If it's the grade of the month, then that's the severity.
That I know on auscultation also, whether in hand systolic. So the thrill indicates the site of disease, site of origin of the problem. Murmur could be going anywhere, conducted. Okay. So thrill is important because it tells you the site. If it's a site of a VST, yes, the murmur is at that. If it's the mitral rigors, murmur is at the thrill at the mitral area. So thrill is important even when you have a murmur.
You have a thrill? Where?
Now, do you expect a thrill in this one? You have said apex beat is in the normal position, cardiac impulse. Okay. So if the cardiac impulse is in the right position and the patient has been admitted for investigation, so she is symptomatic. So do you expect a right-sided? Do you expect
Thrill.
any?
Do you expect a thrill?
Would you expect a diastolic thrill with a normal heart size? The systolic thrill unlikely because you have a regurgitant lesion or any left-sided lesion. But this looks like a right-sided lesion on so far palpation. You'll have to confirm that. So possibly we don't anticipate any such abnormality, right? Yeah, absolutely.
One more thing on palpation.
Palpable heart sound.
Yeah.
So
Open heart sound in particular.
no, that you have to look by the tip of your fingers in the second space.
Tip of the finger.
One.
Yes.
Two or
Left side or right side?
Right side is the aortic area, left side is the pulmonary area.
so you can check both.
will depreciate.
Okay. And one more palpatory finding is thrill along the carotids. So you have to check that.
And of course, palpation, all peripheral pulses. Okay.
With finger. With finger.
So neck is straight in the straight, and then in one groove, stir that carotid groove.
When
Normal
radial is well palpable, do you want to look at carotid?
or characters.
If the radial is all right, the carotid has to be all right. Okay. So in an exam, you did not check carotid, you said, but there is no need. Peripheral. Okay, posterior tibial is okay. So typically, quickly auscultate and then let her go. She's getting a little bored. Auscultate. 1 minute बेटा हाँ अभी 2 मिनट में चले जाओ हाँ वेरी गुड 2 मिनट Why is she holding one finger on the pulse while auscultating the heart?
To differentiate systolic and diastolic. So if the murmur correlates with the radial pulse, it's more of systolic. If it doesn't, diastolic.
Is she looking for a pulse effects deficit?
This also.
So to differentiate, if you are saying systolic, diastolic, you should check with the carotid pulse, not the radial pulse. Okay. So the carotid pulse is supposed to correlate with the first heart sound.
So auscultate this maybe.
There is loud bit too, and there is murmur, most appreciated in the pulmonary area. This systolic murmur. Systolic murmur.
And systolic murmur, the continuous murmur has disappeared because pulmonary hypertension has come in. So it's a typical PDA.
It's not continuous murmur, but it is.
The continuous murmur is lost. Diastolic is lost when the pulmonary hypertension comes. Here it is, so it is a PDA.
So what are the points against PDA? Age, though it must be a ignored PDA, no? Points on signs which are against PDA.
No bounding pulses.
Okay. Then
DA comes with figure.
so when the PDA had a full pansystolic murmur, what was the physiology of the circulation that time? High volume, low volume. So what would have done to the LV?
Wide pulse pressure. We would have signs of Renault. Okay. So all that. Okay. Would the neck vein show that there is a wide pulse pressure? Undergraduates would have known this because they have learned dancing carotids. Okay.
Yeah.
So not important. When did you see dancing? Okay, when you dance because you don't know what is that. So dancing carotid, but undergraduates are impressed by all that. So just look at all those things, right?
So now in this child, tell me, you got LV definite or RV definite, enlargement or neither?
Possibly neither. Okay. I tricked you into say hyperdynamic, but it could be a normal effect. Okay.
So decide.
So first now tell me, she's stable.
Yes,
She has no cardiac dysfunction. Probably her pulse is also okay. She has no cardiac failure. So she has a cardiac lesion which has not affected her in any way. And your findings are at the pulmonary area and a pansystolic murmur, correct? So is it a pulmonary stenosis? Typical, no? Systolic murmur, pulmonary area.
Present with cyanosis.
Why should there be cyanosis? Pulmonary stenosis has no cyanosis. Pulmonary atresia may have a cyanosis, which is there right at the pulmonary stenosis has no cyanosis. So why not pulmonary stenosis in this? Typical, no left ventricle, maybe query right ventricle or normal. Okay. And typical pulmonary stenosis.
And PS, we can get absent P2.
So it need not be absent, it will be a mild P2, but that's not easy to make out,
So
right?
you're right. If it's loud and split, it's not pulmonary stenosis, but it's difficult. So could it be still pulmonary stenosis?
Where did you get the thrill? So then how can it be pulmonary stenosis? The thrill has to be at the pulmonary area, no? If it is pulmonary stenosis, right?
So now what is your anatomical diagnosis? Congenital or acquired? Rheumatic? No, why are you so confident? Older child, rheumatic, common.
Primarily, left-sided valves are more involved. Here, we are suspecting right-sided.
And therefore, you want to say whether it's a valvular lesion or a defect. Two things are different. Maybe valvular also may be defective, like stenosis. Okay. But pulmonary is unusual, tricuspid is unusual in a rheumatic fever. The most common is mitral, sometimes also aortic. So here, where is the anatomy of this? Yes, doesn't matter. Yes. Is it mitral?
You said tricuspid area, so is it tricuspid valve involvement? That's very rare. So out of question.
VSD, pulmonary artery hypertension.
Fine. So now pulmonary artery hypertension is a question mark because you have to be very sure then that P2 is loud, RVH is there, parasternal heave is there, and a VSD which will cause pulmonary hypertension has to originally lead to LVH and then RVH. So then by the time there is RVH, there is biventricular hypertrophy, right?
When there is an early pulmonary hypertension developing in VSD, there is also diastolic murmur, which disappears when the pulmonary hypertension has increased to moderate or severe degree. So always, even when there is no diastolic murmur, make a statement that there is no diastolic murmur, especially if you are going to talk about VSD, right? So your diagnosis VSD. My diagnosis ASD. Okay, comfortable child, no problems, no symptoms, no sign. Okay, just the murmur. Okay. So could it be ASD? Don't tell me fixed plate and all that. Don't have that fixed idea. We can't make out a fixed plate. Split or no split is big enough for us. So what is against ASD?
There's no thrill in ASD and certainly not in the tricuspid area. So if that finding is right, then this is not.
Yeah.
Okay, chalo, let's see.
So now one of you before we ask her to go, she can go. लेके जाना भी उसको नींद भी आ गई. Okay, thank you.
Alina.
ये ले इधर देख क्या देते हैं क्या दे ये देखो ले लो वेरी गुड मम्मी को दे दो So meanwhile, one of you will tell me what should be the history of this child. Then we'll ask her to present. Which cardiac symptoms she must have come? I know breathlessness. You think she came with breathlessness? I know cough. Did she come with cough? I know she has a general weakness, tiredness, exertional dyspnea. Okay, palpitation. So, which of these symptoms she must have come with? And why do you say, looking at the examination finding, which symptoms she must have come? There is an occasional person who can write with left and right hand and can meet. Okay, he would be knowing. Okay. So we can go that way. Normally history first, examination you anticipate. Today we are examining first and anticipate history. This is the best way to learn. And only to know that, oh, we did not know many things. Because first inspiration to learn is to know that you are not able to understand even now. That's what I also keep on doing. I come here to teach only to learn. Okay. So come on, meanwhile, you tell us what symptoms, she will say yes or no. Then she will quickly present all that. Oh, look at that. Totally different, no? Stools, vomiting, paroxysmal event, and here nothing, only heart. Come on, one of you, just guess, doesn't matter. She could be already better, okay. But at least it tells you that she came with some symptoms serious enough to be hospitalized and now is totally normal. Even that's fine. Okay. If somebody gets admitted at 2 o'clock in the morning, early morning, and by around at 9 o'clock, he looks perfectly all right, you can guess that he could have an asthmatic episode, he could have an epileptic episode. So you can start thinking which serious illnesses get almost normal in few hours time after hospitalization. Pardon? Yeah, so she may have had a palpitation or maybe she's exertionally dyspneic. Okay, but nothing beyond that. Okay. The other thing is that if you are suspecting VSD in particular, but any cardiac defect, look at the syndromic probabilities because many of these cardiac defects, in particularly VSD, has a lot of other areas which are also abnormal, and therefore a diagnosis of syndrome in which VSD is the only presentation. Like a Downs may only present with cardiac defect. So always make a note that you don't have any syndromic features like a facial abnormal physiognomy or number of phalanges. Okay, all those things.
चल बेटा चल आ जा
ले जाओ भाई ना
सो जा
ले जाओ थैंक यू
So the heart size is normal. There is no enlarged heart. There's
जो
no
मम्मी उधर है
LV.
हमें उधर है हमें उधर है हाँ ले जाओ
There's no LV and there's no RV also.
मतलब teaching
Clinically.
so boring I was looking at each one of you okay
And in fact, the first heart sound is loud in the mitral area, which we can further explain on the thin chest wall,
Thin chest
etc. Then the second heart sound is again borderline to loud
So
in
near
the
normal.
pulmonary area, so maybe normal, and there's a systolic murmur in the pulmonary. There is no thrill or any,
No cardiomegaly.
no cardio.
So only the systolic movement in the pulmonary area, classical ASD. Okay, and now tell me what symptoms you must have come with.
ASD will not be something.
Somebody heard a murmur, so she came. Okay, now tell us you present your thing.
त्यासाठी AC बंद केलं होतं पाहिजे का?
हा नाही बस.
असू द्या.
7-year-old girl child taken by court order, born of non-consensual marriage, resident of Bandra, brought by parents came with treatment of 5 episodes of paroxysmal event in 3 days, vomiting since 1 day, loose stools in 1 day. Judge,
Have you ever seen loose stools and vomiting with paroxysmal? Very funny, isn't it? I was a pro of paroxysmal eruption in 3 days. And thereafter vomiting and loose. The first food is only several episodes of paroxysmal. Funny, no? Forget the those things vomiting. Okay. What is this paroxysmal event? 5 episodes in first 2 days. Give a thought. Normal child, possibly. Okay. So you just start saying that she was absolutely on
No,
the
that's
So normal child has multiple episodes of paroxysmal event. Do you understand?
Whether this is Caesar or non-Caesar is the first question.
Very good.
This could be syncopal mimic like syncopal attack. At this age, we don't expect breath holding spell. Syncopal attack could be one.
This side breath holding, etc. doesn't come much. For any seizure, you must start thinking, of course, confirm it's a seizure. And how do you confirm it's a seizure in this?
The typical history of either Caesar semiology, uprolling, tightening of tonic, and then post-ictal drowsiness, and
Respiratory factors. Is there any significant birth or ANC history? Is there any drug history? Is the child already on some medication? Is there any history of trauma on the basis of
The most important is okay, that's where we say looking at one side, but eyes are open. Okay, and then there is a change in sensorium if it's a verbalized seizure. Maybe for a short time, maybe 10 minutes, 5 minutes. So which once we confirm a seizure, next is acute symptomatic, remote symptomatic, or idiopathic. What will this be?
We don't know the birth history and the past history. If there is birth history, can be remote symptomatic.
Rajesh, we cannot hear anything.
मॅम ऍक्च्युली चोखानी सरांचा जो हे होता ना कनेक्टिव्हिटी ती बंद झाली आहे. आय एम ट्राइंग टू कॉल देम.
Okay, okay.
Hello? Ma'am, we cannot hear you.
We cannot hear the discussion. Oh, we can't hear.
मॅम चोखानी सरांना फोन लागत असेल तर ट्राय करता. माझा नाही पिकअप
हो
झाला.
चालेल. ओके.
थँक्यू.
नाही, अर्चना पण फोन उचलत नाही आणि राजेश पण नाही. स्विच ऑफ येतोय. त्यांचा बॅटरी डाऊन झाला असेल.
मॅम ते कनेक्ट होत आहेत का वाट बघूयात मग. Archana ma'am, if you can hear me, we cannot hear the discussion because second device is switched off, I think. नाही सर, ऐकू नाही येते. नो सर. राजेश सरांच्या मोबाईलवरचं जे कनेक्टिव्हिटी होती ना ती बंद झाली आहे. इफ यू कॅन रिस्टार्ट दॅट वी कॅन हिअर.
नाही पल्लवी, काहीच ऐकू येत नाही.
हो सांगते. चालेल, सांगते सर मी. ओके ओके. हो हो चालेल, काही प्रॉब्लेम नाही. ओके मॅम, देर इज अ ऑडिओ इश्यू. we continue like as it is.
विल डिस्कनेक्ट मग.
सर म्हणतात कंटिन्यू राहू द्या, काही शेअर त्यानंतर राहू देत म्हणून. ओके
चालेल. ओके.
येस मॅम, थँक्यू.
ओके.